We'll first cover the antidepressants, and the first class is the SSRIs. Now, Prozac was the first SSRI marketed in the US in 1988, and it was basically seen as a favorable alternative to the tricyclic antidepressants, which had a lot of bad side effects, and they were not as safe. In other words, Prozac could be taken in high dosages without it being lethal. You can see in addition to depression, there are many other FDA indications, including anxiety disorders, OCD, PTSD, premenstrual dysphoric disorder. And between each medication, there are differences in pharmacodynamics, pharmacokinetics, side effects that can affect the clinical response in individual patients. They're believed to work by inhibiting serotonin reuptake by the neurons. And basically the way that works is that you've got neurons with serotonin inside them. They get released. Once the serotonin is out in the open, they act on other neurons, and that activation creates downstream effects. After they do that, the original cell will take back the serotonin into itself. That's called reuptake. And so what these medications do is they block that reuptake mechanism, and as a result, you have more serotonin floating around doing its thing. And effectively, what that means is that these meds increase serotonin. The SSRIs are the first-line recommendation for depression, both due to their safety and their efficacy. As I mentioned before, no single SSRI is superior to another. Studies have shown that over 50% of patients who respond poorly to one SSRI will respond favorably to another. So you might see patients who have tried a few or several in the past. There is a black box warning, which we talked about suicidal thoughts in children and adolescents. Some clinical pearls include Prozac, which has the longest half-life. Paroxetine has been previously classified as category D in pregnancy because it increases the risk of heart defects in the fetus. When we use the SSRIs to treat OCD, the dosages need to be considerably higher, almost double sometimes. So, for example, Prozac, you can give anywhere between 20 to 80 for depression or anxiety, but if you're treating OCD, you can give 100, 120, or even up to 160. And a good trial of an SSRI for OCD is actually considered 10 to 12 weeks, which is 3 months. So patients need to be on these medications for 3 months before we can reasonably say that the medication is effective or not. When treating premenstrual dysphoric disorders, some people choose to take the SSRIs continuously. Other people only take it during the luteal phase, which is the 2 weeks between ovulation and menstruation. Still, other people just take it when they have dysphoric symptoms before and during their period, as long as they last. It should be said that all SSRIs can cause sexual dysfunction, such as anorgasmia, inhibited orgasm, and decreased libido. The other side effects are listed on the slide. So I usually tell people they can take their SSRIs in the morning or at night, depending on how it makes them feel. If it makes them more tired, they can take it at night. If it kind of wakes them up, they can take it in the morning. Emotional blunting is the feeling of numbness, apathy, or indifference, or the inability to cry. Most people don't like it because they feel like they don't have a full range of their emotions. Although I had met one patient in the past who said that something along the lines of, my life is so chaotic, I should be crying every day at what's going on, but thanks to these meds, I'm not, and I can get out of bed in the morning. So I told her, maybe over the long run, that's probably not the best strategy, but in the short run, if she's able to function, then I was okay with that. One last thing to mention, if you combine the SSRIs with other meds that increase the levels of serotonin, you just have to keep in mind the possibility of serotonin syndrome, which is rare. What it is it's a set of symptoms that includes diarrhea, restlessness, agitation, autonomic instability, and it is considered a medical emergency. The SNRIs are the selective serotonin norepinephrine reuptake inhibitors. Effexor received FDA approval in 1993 for depression. There are currently 4 SNRIs that have approval for that in the US. Savella has FDA approval for fibromyalgia, but it is used for depression in other countries. They're basically similar to the SSRIs in that they block the reuptake of serotonin, but also norepinephrine in addition. So essentially, they increase serotonin and norepinephrine. They're sometimes called dual reuptake inhibitors, and the argument is that by increasing both serotonin and norepinephrine, they could have a greater antidepressant effect. So the indication, safety, tolerability is also very similar to the SSRIs. Nausea is the most common side effect of venlafaxine and desvenlafaxine. And due to the nausea from these medications as a class, they're rarely used in the immediate form. So almost all of these come in extended release. Other common side effects with this class of medication include headache, insomnia, dry mouth, dizziness, constipation, sweating, and nervousness. Discontinuation syndrome is particularly problematic with this class of medications also, and it occurs if people stop them abruptly. I've had a few patients tell me that if they don't take their SNRI within the same hour of the day, they'll start to feel some of the discontinuation symptoms. Duloxetine also has FDA approval for neuropathic pain, such as caused by diabetes. And so you might see a patient who is on an SNRI for any type of nerve damage after an injury, and it can also be used for stress urinary incontinence. I group these three antidepressants together because they're commonly used for depression, but they're not considered SSRIs nor SNRIs. Wellbutrin is very well known, came out in 1985. It inhibits the reuptake of norepinephrine and dopamine, effectively increasing both. It's about as effective as the SSRIs in treating depression. We can also use it for seasonal affective disorder. The brand name Zyban is essentially bupropion, and it's used for smoking cessation when you combine it with nicotine replacements. Wellbutrin can also be used as second-line medication for ADHD due to the increase in dopamine. And so it can be a good medication for someone who has comorbid depression and ADHD. Another interesting property about Wellbutrin is we sometimes use it to counteract the sexual side effects of the SSRIs or the SNRIs. Wellbutrin itself can improve sexual arousal, orgasm completion, and sexual satisfaction. Also in clinical practice, most people notice that it tends to work better for depression as opposed to anxiety. Mirtazapine increases norepinephrine and dopamine, but not through reuptake inhibition, which is why it's considered in a different class. It's effective for treating depression. The two things to note is it's highly sedating and it causes an increase in appetite. So a lot of people don't like it for that, but the ideal patient who you can give it to would be someone who's depressed, maybe with insomnia, weight loss, and possible agitation. It can also actually reverse the GI side effects of nausea that might be induced by certain chemotherapy medications. And we often combine it with SSRIs or SNRIs as well. Sometimes I also give it for sleep in small dosages, 7 milligrams, 15, sometimes 30, depending on the patient. Trintellix is the new kid on the block. It is similar to the SSRIs in that it inhibits serotonin reuptake, but it also antagonizes other serotonin receptors, and so that makes it unique. It has FDA approval for depression as of 2013, although it is not available as generic. They do market it also similar to Wellbutrin as not having the sexual side effects of the SSRIs, and so that is a selling point for it. And so you might find samples lying around the office. We are waiting for this to become generic because it does work very well. One of the main side effects that I see is nausea and stomach upset. The tricyclics I'll talk about briefly because they're not used very often today. In 1957, imipramine came out, and it works by blocking the serotonin and norepinephrine transporters. The reason that they're not used as much is because the SSRIs and the newer antidepressants have better safety profiles, and they can target the specific receptors with fewer side effects. That being said, the tricyclics still are seen as very effective for depression, and sometimes we use it when there's treatment resistance. Let's see, clomipramine is one of the TCAs that we use often for OCD in the US. Amitriptyline can be used for neuropathic pain. We do pay attention to anticholinergic effects, which include dry mouth, constipation, blurry vision, urinary retention. Cardiac effects are profound, sometimes tachycardia, EKG changes, and orthostatic hypotension is something that we watch out for. It does cross the placenta, so we don't give it in pregnancy, and overdose with TCAs can be fatal, so you have to be very careful if you have a patient who has suicidal thoughts or a history of suicide. The MAOIs are used even less than the TCAs, They were actually the first class of antidepressants approved in the 1950s. Isoniazid is a treatment for tuberculosis, and what happened was they were giving all these people with TB that medication, and they noticed that their mood was suddenly increased. So they started to develop this class of medications around that. Now, the way these work is you have an enzyme called monoamine oxidase, which metabolizes all those neurotransmitters, norepinephrine, serotonin, epinephrine, dopamine. And so when you give this drug, which inhibits the monoamine oxidase, the net result is that these neurotransmitters increase. Now, unfortunately, monoamine oxidase is also involved in the metabolism of tyramine, the amino acid. So when you inhibit that with these medications, tyramine goes straight into the bloodstream intact, and the result is that it elevates the blood pressure. So anybody taking the MAOIs need to be very careful about taking any medications that have high levels of tyramine in them. So, for example, certain aged cheeses, fish, cured meats, and specific alcoholic beverages contain tyramine. And worst case scenario is if you've got tyramine in you when you're on an MAOI, it could result in very high blood pressure and a hypertensive crisis. In addition, you also want to avoid taking any other antidepressants before and after you're taking the MAOIs. I grouped together these medications, which are generally used for anxiety. Buspar is a very benign medication. It works on serotonin and dopamine. It's approved for treating generalized anxiety disorder. It's often added to the SSRIs or the SNRIs, and the plus side is Buspar doesn't have the sexual side effects or the weight gain of the SSRIs. On the other hand, a lot of patients say that it's not very effective because it tends to be more benign. Both Benadryl and hydroxyzine are antihistamines, and they're used in the short run for anxiety or sleep. So you've probably heard of ZQuil or seen it on the shelf in the drugstore. And basically, if you look at the active ingredient in ZQuil, it's diphenhydramine. So what they're doing is they're marketing liquid Benadryl, giving it a new name, and they're increasing the price by like 2 to 3 times. So I generally tell any of my patients, I'm like, hey, if you like using ZQuil for sleep at night, try buying Benadryl. It's like a third of the price, and see if you get the same effect. Most people do. Some people swear that ZQuil works, but Benadryl doesn't for whatever reason. I don't know why. Those are both first generation antihistamines, and the second generation ones you also probably know, which is like Claritin, Zyrtec, or Allegra. The second generation ones we tend not to use in psychiatry. They tend to be less sedating. Gabapentin and pregabalin are technically anticonvulsants. They can be used for seizures as well as neuropathic pain, diabetic neuropathy, fibromyalgia, headaches. In psychiatry, we tend to use them for anxiety, maybe even social phobia, panic disorders. Gabapentin can also decrease cravings for alcohol, and the side effects are basically somnolence and ataxia and fatigue. The dosing range for gabapentin is pretty wide. You can give as low as 100 milligrams and as high as 2,400 milligrams in a single day in divided dosages. Finally, we talked about propranolol. Propranolol is a beta blocker. We can use it in psychiatry for social phobia, such as stage fright. So if someone wants to take it before a presentation, they can. Other beta blockers that we sometimes use are atenolol, metoprolol, pindolol. What you have to keep in mind with the beta blockers is sometimes they affect other receptors, such as around the lungs and the heart. So when patients have asthma or diabetes or congestive heart failure, you have to be careful about which one that you use. Librium was the first benzodiazepine introduced in 1959, and then it was followed by Valium in 1963. When they came out, they were seen as generally safer than the barbiturates. The drugs act on what's called the benzodiazepine receptor, and the net effect is it increases GABA. GABA is the main inhibitory neurotransmitter in our body, and it's also increased when you drink alcohol. So the benzodiazepines work very similarly to alcohol. They have a very rapid anxiolytic effect, and it makes them useful for insomnia, anxiety, and agitation. Some of my patients ask me for like a very small dose of Xanax or Klonopin if they're about to fly on a plane, or if they go to the dentist, or if they have like a closed MRI, and I'm usually happy to give them that in small dosages. You might have also heard the very interesting case in 2017. There was a nurse, her name was Rodonda Vaught. She was actually charged with reckless homicide because there was a patient who was about to get scanned, and the doctor had ordered Versed, which is midazolam. You can see it on the left. And when she got the medication out of the machine, instead of giving Versed, she actually gave vecuronium, which is an anesthetic. So what happened was the patient took the vecuronium, had cardiac arrest while she was lying in the machine, and then suffered brain damage. Very unfortunate. I don't know the outcome of the case, but you can look it up. Things that we think about when we prescribe benzodiazepines are half-life, which determines how long it stays in the body. So longer half-life drugs have the advantage of less frequent dosing, but they also increase the risk of daytime sedation and somnolence. So for elderly people, we tend to want to give benzodiazepines with shorter half-life, such as Xanax or Ativan. And we try to avoid the ones with longer half-life, such as Valium or Klonopin. And it's generally agreed that benzodiazepines should be given for only a short amount of time. However, we do sometimes see patients with chronic insomnia or anxiety. Long-term treatment is sometimes warranted. Of course, the main thing that we worry about with the benzodiazepines is combination with other drugs that have sedative effects. So it should not be combined with alcohol, barbiturates, tricyclics, antipsychotics, and especially opioids. That's one thing that I have to tell patients very often. I'm like, okay, you're on oxycodone. I really can't give you a benzodiazepine, or if I do, it has to be in a very small dose. And withdrawal symptom can also occur if you stop the benzodiazepines too abruptly. So the general recommendation is decreased by 25% every week. Benzodiazepine withdrawal looks exactly like alcohol withdrawal. It can result in seizures and delirium tremens, and that can be a medical emergency in which you end up in the hospital. The non-benzodiazepine hypnotics are listed in the top left. That's Ambien, Lunesta, and Sonata. The reason they're called that is they act on the same receptor as the benzodiazepines, but it's a different subunit. And so they have sedative effects, which is why they are released for sleep and insomnia, but they don't have the muscle relaxant and the anticonvulsant effects. And there is a black box warning on them about sleepwalking and sleep eating. I have patients who have told me that they've taken Ambien and they got up in the middle of the night, made themselves a sandwich, maybe got into their car, drove around, and then they come back to their house and they don't remember a single thing. So that is something that can be very concerning. I believe there were 2 cases of Ambien-related homicide where they were trying to figure out, did the Ambien contribute to the fact that these people killed someone else while on the medication? That's also something that you guys can look up. The other medications that I listed are medications that we've talked about before from different classes that I sometimes give for sleep. Amitriptyline and doxepin are TCAs I give in small doses. Trazodone I'll give very often, older antidepressant, but now we use it for sleep. Seroquel is an antipsychotic that we give, like I said, in small doses for sleep. So lithium was discovered in 1950 to be effective for mania and manic depression. There were concerns about toxicity, so it didn't get FDA approved until about the 1970s. Lithium is on the periodic table. It is a natural element. We mine for it in Chile and Argentina. You probably know that Kurt Cobain was on lithium. He wrote that song titled Lithium. And we're not really sure how it works, but we believe it has to do with ion transport. Lithium, in addition, can be used as add-on therapy for major depressive disorder. It also reduces the incidence of suicide in bipolar disorder. There are certain things to keep in mind, such as salt, which can lower the lithium concentration. Dehydration can increase the concentration. It does have common side effects like GI symptoms, weight gain, tremor. We generally have to monitor lithium, the blood levels, to make sure that they don't become too toxic. We also like to keep an eye on kidney and thyroid function because it affects those as well. There is some concern of Epstein's anomaly in pregnancy in the fetus if a mother is taking lithium while she is pregnant. Lamotrigine was developed for partial seizures in the US in 1995, and it was approved for bipolar disorder in 2003. It works by blocking the sodium channels, which have downstream effects on glutamate and aspartate. Sometimes we use it for borderline personality disorder. One thing to keep in mind about Lamictal, even though it has a very good side effect profile and we don't need to do blood work for it, about 8% of people get a benign rash within the first 4 months. Stevens-Johnson syndrome and toxic epidermal necrolysis is a rare but life-threatening rash. The risk is somewhere between, they say, 0.08 to 0.13%. And so I always tell my patients, if I start them on Lamictal, it's a very good drug, but you need to check your body every day for rashes. There are some interactions between Lamictal and Depakote. Depakote will double the dose of Lamictal inside the body. Depakote is approved for bipolar mania, more effective for mania as opposed to depression. It's a carboxylic acid, but the mechanism of action is not well understood. We can use it for seizures, alcohol withdrawal, impulse control, anger issues. There are black box warnings about Depakote about hepatotoxicity and pancreatitis. We generally don't give it to females of childbearing potential because it can cause neurotube defects in the fetus, such as spina bifida. There are GI effects. A lot of people complain about hair loss with Depakote. The last three mood stabilizers, carbamazepine, trileptal, and Topomex, are, I believe, third-line recommendations for bipolar disorder. They're all anticonvulsants. Topomex can be used in migraine prevention, obesity, bulimia, binge eating, even alcohol dependence. Carbamazepine is similar to trileptal. Trileptal lacks some evidence with bipolar disorder, but it is usually given if carbamazepine doesn't work because they are very similar in structure. This is an advertisement for Thorazine, or actually two advertisements for Thorazine, which came out in the 1960s. So you have to understand that Thorazine was really the first medication that successfully treated schizophrenia and psychotic symptoms. So it really was a major breakthrough back in the 1950s. It belongs to the class of medication that we call the first generation antipsychotics. They're not as commonly used today as the second generation antipsychotics because the first generation cause a lot of extrapyramidal symptoms. Extrapyramidal symptoms include Parkinsonism, akathisia, and dystonia, which I discussed before. On the plus side, the first generation antipsychotics are less likely compared to the second generation ones to cause metabolic syndromes, weight gain, glucose abnormalities, those types of things. There are long-acting formulations, which we call depot. You generally give by intramuscular injection every 1 to 4 weeks. That can be good for patients who are non-compliant, forget to take their meds or don't believe that they need to. In addition to treating any condition with psychotic symptoms, the first generation antipsychotics are also used to treat bipolar disorder, whether depression or mania. So for that reason, when I prescribe the antipsychotics, I usually try to tell people, antipsychotic is not a great name. What they really should be called is dopamine blockers or dopamine receptor antagonists, because the net effect is that they decrease dopamine, and they're not always used just for psychotic symptoms. In addition to bipolar, sometimes if you're in the ER, one of the favorite combinations people use is what's called a B52, and that's a combination of Benadryl, Haldol 5 milligrams, Ativan 2 milligrams. It's generally given to patients who are agitated and possibly violent, and it kind of sedates them very quickly. So second generation antipsychotics, also called atypical antipsychotics, atypical because they have a better side effect profile compared to the first generation ones. These are ones that are commonly used, so if you notice on the left, you'll probably recognize a lot of the names. Again, they have a lower incidence of EPS, but higher incidence of metabolic symptoms such as weight gain, cholesterol increase, glucose increase, and for this reason, anyone on an antipsychotic, we generally monitor their weight. We do lab work every year or every 6 months. What's also different about them is they act on serotonin in addition to dopamine. Some of them are also approved in addition to the same indications as the first generation ones. The second generation ones are also approved for augmentation to antidepressives. So for example, Abilify and Rexulti I use pretty often by adding on to an antidepressant in case the antidepressant monotherapy doesn't work. Other indications for antipsychotics include aggressive or violent behavior, AIDS, dementia, autism, Tourette's, Huntington's. Treating dementia and delirium is somewhat controversial, but it is done pretty commonly. Clozapine, as I mentioned before, is basically seen as probably the most effective antipsychotic as far as the class goes. We typically reserve it for treatment-resistant conditions and people who have failed at least 2 other antipsychotics. The reason being is that with clozapine, it can cause a decrease in the neutrophils, which is known as agranulocytosis. So anyone who's on clozapine needs to have their blood monitored periodically, every few weeks to every month, depending on how far they are in the treatment. So it works very well, but because of the high maintenance that you need, we tend to not use it that often. Stimulants are used to increase motivation, mood, energy, wakefulness. What they do specifically, they increase dopamine and norepinephrine. They were first created, interestingly enough, in the 19th century, and they were used by Bavarian soldiers to keep awake and alert in combat. Nowadays, we obviously use them for ADHD and narcolepsy. We can also use them for treatment-resistant depression, neurological effects caused by trauma, tumors, chronic conditions. They also suppress the appetite. So one that I did not list here is phentermine, and that's commonly used for obesity and appetite suppression. Multiple sclerosis often causes fatigue, and we can counteract that by using stimulants as well as modafinil. So when you're looking at the stimulants, there are basically 2 broad classes. You've got your amphetamines and you've got your methylphenidates. The methylphenidates are generally given more in pediatrics and the amphetamines for adults, but not always. They are Schedule II controlled substances, so refills are not allowed. Clonidine and guanfacine work on the alpha receptors, so they're used in blood pressure, but also in addition to stimulants or in place of them. Strattera is generally used if we don't want to give certain patients stimulants for side effects or another reason, and it could be a good alternative. We also like to monitor blood pressure because stimulants can increase that, and certain cardiac conditions are contraindications to stimulant usage. The last category of medications that I'm going to talk about only briefly is substance abuse. So in general, opioid receptor agonists are drugs that work on the opioid receptors and they're used for pain. Examples would be Dilaudid, oxycodone, codeine. If you watched House, Vicodin was the one that he was abusing. Heroin and fentanyl are street drugs, but they are considered opioids. And for anyone who wishes to get off of them or to detox, methadone acts on the same receptor with fewer euphoric effects. So it can be used as maintenance treatment. Buprenorphine is the next level down. It's a partial agonist, which means it has a partial effect on the same receptor. It's combined with naloxone to prevent abuse through the IV route. And because it's a partial agonist, it can also precipitate withdrawal. So you have to make sure that your patient is completely off of the opioids before you actually give it. So methadone is only given in specialty clinics, whereas Suboxone can be prescribed often in sublingual form. For alcohol use, there is disulfiram, acamprosate, and naltrexone. Disulfiram is interesting because what it does is it alters alcohol metabolism and it causes acetaldehyde to not get broken down, and when it accumulates in your body from alcohol, it produces the disulfiram alcohol reaction, which basically comes with nausea, headache, vomiting, flushing. And so people who are on disulfiram know that they can't drink because that's what their reaction is going to be. Of course, it's easy to get around that because all you have to do is not take your antabuse that particular day and then you can drink. So it's really good for someone who is very motivated to not drink. Acamprosate is good for someone who's already stopped drinking, and it works on the glutamate system, and it's said to reduce the cravings for alcohol. Naltrexone is an opioid receptor antagonist, which means it attaches to the opioid receptor, but it has no effect. It's similar to naloxone, which obviously people give as, the rescue medication for opioid intoxication. So a common sequence of treatment would be first giving someone methadone, then stepping them down to buprenorphine, Suboxone, and then finally giving them naltrexone. And naltrexone was also approved to treat alcohol dependence in 1994. Similar to acamprosate, it reduces cravings as well as consumption. And lastly, there is Chantix. It works on the nicotinic receptors, named because those are the receptors that nicotine works on. It causes a smaller release of dopamine than does nicotine, so it reduces that pleasure effect that people normally get from smoking or nicotine directly. There was a massive recall of Chantix in 2021 by Pfizer because there was a substance that they thought could cause cancer, and so as a result, many generic options are available right now. Now, of course, there are a lot of other medications that we use in psychiatry. I try to focus on only the most common ones, so hopefully this will be helpful to people who are not prescribers or even people who are prescribers with less experience. And if there are any questions, please feel free to reach out to me. Thank you.